Hi there, Kay here, and I'm going to be taking you through Module 8. So let's get that up on the screen for us now. Oh, right. Okay, so component 5, abuse and addictions, and Module 8 is self-harm and feeding and eating disorders. So let's firstly look at the standards for today. So you'll be able to understand addiction issues, summarising your understanding of self-harm, self-injury and eating disorders. Discuss what assistance a therapist may be able to provide for a client who's been diagnosed with an eating disorder. And understand the use of counselling supervision. So summarise the 7-eyed model of supervision and use this to reflect on your own supervision, and discuss what you believe the role of a supervisor to be, focusing on support for the supervisee, support for the supervisee's client, and responsibility towards their organisation and their profession as a whole. So we're going to be looking at those two things today. So we're going to start with self-harm, but both self-harm and eating disorders are severe self-defeating behaviours. So let's firstly remind ourselves what a self-defeating behaviour is. Well, it's never the best course of action for a person. It would have at one time been used as a coping strategy to deal with a difficult situation, and it also ensures that the consequences the person is trying to avoid will come to pass. And if you remember, you learned about that in year 2. So let's look at a possible model for how self-defeating behaviour develops. So there will have been negative past experiences, and that could be abuse, trauma, neglect, lack of emotional support, and that will have left the person with a negative view of their self, low self-worth, and possibly anxiety or depression. And obviously those feelings are difficult. There's a growing tension and the urge to reduce that tension. And that's where the self-defeating behaviours come in. So the more complex self-defeating behaviours that we've looked at is substance abuse and process addiction, and today we're looking at self-harm and eating disorders. And when they do those things, there's a temporary dissociation, or there's respite from that tension that they're feeling. They get something else, a bit of a comfort from doing these things. So that's how it possibly develops. Now, obviously, it's a very difficult and challenging field to work in, and you need to always be thinking about your own competency levels. So we'll start with self-harm, which is defined as any act of self-poisoning or self-injury carried out irrespective of motivation. And that can be self-poisoning with medication and injuring by a range of different methods, but the most common is cutting. But of course, there's also burning, banging your head, hitting or punching yourself, picking at skin, chewing the inside of your gums, swallowing sharp objects, even breaking your own bones or worse. But we'll focus mainly on cutting because that's the most common thing. And when people cut, they tend to choose areas that they can cover up easily, although not everybody does. That might be the tops of the arms or the tops of the legs or the chest commonly. And when people are doing this, they don't usually feel pain. It can feel like a release for them, and they don't feel pain until maybe afterwards. And that release helps them to feel calmer. Some of the factors that people give for self-harming are hopelessness and depression, family circumstances that are difficult, a disruptive upbringing, and ongoing family relationship problems. And there's also a link between childhood sexual abuse and self-harm. Now, it's a maladaptive coping mechanism, and so it's a way of expressing difficult emotions. It's the only way that they know to express their difficult emotions. And people who do this often find the physical pain is much easier to deal with than the emotional pain. Let's look at some of the reasons that people have given as to why they do this. So things people have said are to feel something other than emotional pain, to ease tension and anxiety, to escape feelings of depression and emptiness, to relieve anger and aggression, to regain control, to maintain a sense of uniqueness, to obtain a feeling of euphoria, to express and cope with feelings of alienation as a response to self-hatred or guilt, as a continuation to previously abusive patterns, in a response to confused feelings, and as a way of communicating feelings, needs, or wants that the person has trouble doing verbally. But of course, the self-harm only provides temporary relief. It doesn't address the underlying issues. Now, self-harm is most common in young people, and they often feel unsupported, although that might be their perception rather than the reality. I've worked with a lot of young people, and they know that their parents would be there if they wanted to talk and express things, but they just can't. And self-harm is more common in girls than boys. However, boys may engage in different forms of self-harm and may do more of the hitting and punching themselves and possibly headbanging. So when we're thinking about self-harm, it can be quite a scary subject, especially for therapists in training and new therapists. But we need to remember that it's generally life-sustaining. So most people who do this do not want to end their life. It's a coping mechanism. But people can experience a buzz from it, from the release of endorphins when they cut, which creates that euphoria, then calmness. And people do unfortunately die from cutting too deep, or from infections that occur from using dirty instruments. So it's clearly important that therapists assess the risks involved. So questions that you could ask are, whereabouts are they cutting themselves? Do they know the dangers of cutting too deeply or in certain places? And what instruments are they using to cut? And are those instruments clean? Now, whether self-harm is an addiction is still up for debate, and we know that it is habit forming, and the experience of pain can become addictive. And there's also the effects of tolerance, in that people often need to cut more deeply or more often to get the same effects. Now, as a counsellor, you may get someone who presents with self-harm because they want to try and change that. Or you may get somebody that comes with another issue. That could be depression or anxiety or something else. And you might notice self-harm, you might see their arms, or they might discuss it during the course of therapy. And many young people have said that if they had someone to talk to, they might not have self-harmed. And it's also helpful for them to know that they're not the only person that feels that way, and they're not the only one that self-harms. And young people who self-harm talked about wanting a support person or a counsellor, but not a teacher, who would engage with them on a more regular basis, not just when they were facing difficulties. So obviously that need to just talk about their feelings and have that regularly can be really beneficial for young people. And many felt they would benefit from more active parenting and wanted more love, attention and care from their parents. And some of those young people commented on serious problems at home. It could be parents in conflict, or were separating, or used substances, or had some other issues that made it difficult for them to be emotionally available and talk to the teenagers. But also, parents are really important because they are seen as a source of support and advice as well. But other help that's available out there, you know, a lot of young people turn to telephone support with places like Childline and the Samaritans. And it's important for them to have those numbers. So I think it's always good for therapists to have a list of relevant organisations that could help someone with different problems, so that we can pass on that information. And therapeutic and emotional support is usually available in most schools, and the charity Place to Be, and some of you may have had placements with Place to Be this year, and they provide therapeutic and emotional support in schools. And the aim is really to deliver early intervention to children across the UK. But although self-harm normally starts in teenage years, it can go on, it can remain as a coping strategy coping strategy long into adulthood, the same as addictions. So we need to bear that in mind. It's not only young people that do it. So how can we help a client? It's not appropriate to ask a client to stop while they're in therapy. But before we do anything, we need to assess the risk. So we need to work out whether they've got a minor habit, such as nail biting or skin picking, which can be seen as self-defeating behaviour, but it's not particularly life-changing. And then there's common self-harming acts like delicate skin cuts, maybe minor burns and pulling hair out, which obviously are not good, but they're not as serious as some other behaviours, such as deep cutting, swallowing objects, taking overdoses and actually mutilating yourself. So we're trying to assess the level of risk, and that will inform whether we can work with somebody, whether we need to refer them on, and how we will work with them. Now, if you suggested to someone that they needed to stop their self-harm when they come to therapy, that's not going to be helpful because it's their coping mechanism and they don't know any other ways of coping at the current time. And so you would lose the trust of the client. It's also important that the client understands that therapy isn't a substitute for self-harm and that you as a therapist can't be there for them all the time. And that's why they need the numbers of other people that maybe can help them when they're in a crisis situation. Now, for parents, it can be difficult because a parent might be desperate for their young person who's self-harming to come to counselling, and they think that you're going to help that person stop self-harming. Well, hopefully you will long term, but in the short term, it can be difficult for parents to understand that the person still needs to continue with their self-harming behaviour. And Reeves points out that a lot of therapists feel great anxiety when they are working with clients that are more at risk. And, you know, our own anxiety can affect how we work with a client. Our personal feelings about self-harm can come into it. Obviously, if we're working in an organisation, there's policies and procedures we need to follow. And our own confidence and competence, how capable we feel of working with somebody at high risk, is going to have an impact. We need to, well, Reeves believed that we need to take a relational approach, but that it can be in danger of being taken over by risk assessment, that we can be so obsessed with the risks that it can affect the way we work with somebody. And the primary purpose of risk assessment is to weigh up the dangers, the things that might make harm more likely, and also the things that might make harm less likely, and also looking what other support is there. And also if the client really wants to engage and how motivated they are. And that will help us reach a conclusion as to the best course of action to take. And we must remember that we can't take responsibility for our clients. You know, unless they lack capacity, then they are responsible for themselves. We can support and encourage and try and help, but we can't control what happens outside of the therapy room. And we need to remember that we're not responsible for their behaviour. So in a pluralistic approach, the client's an active participant in the therapeutic process, and we promote the principle of shared responsibility around risk, with the client being asked to identify what can help them. So when they're in a difficult situation, it can be agreed that they will contact a certain person or do a certain thing that can be helpful for them at that time. And we mustn't be frightened of talking about the self-harm or even suicidal ideation. We mustn't avoid those conversations. That's not helpful. It actually helps the client to get a clearer sense of what's happening to them and explore more openly their own emotions and feelings. So in the pluralistic approach, we might make a crisis plan with somebody. You know, who can they contact? Who can support them when they're feeling bad? What can they do to make themselves feel better? And there should be clear agreements on the goals of therapy and boundaries, such as for what reasons they can contact you. You know, if they've got someone else they can contact, telephone lines, or a family member, someone they can trust or talk to, then you won't be contacted at all hours. You know, you need to set boundaries, otherwise you could have clients contacting you when they're in a crisis, and you might not always be available. For one thing, you might be with your family members. You can't just be called upon all the time. So they need to understand that. And it's also good to give them advance warning of when you're not going to be available, if you're going on holiday or something. And they need to understand the limits of confidentiality, because obviously if you think they're at risk of severe harm, you would need to do something about that. So with self-harm, all models of therapy can be useful. Person-centered therapy, obviously using the core conditions, and allows you to build trust and rapport, and allows the client to not feel judged and to tell their story. And they may not have been able to be open and express themselves fully with anyone else. But the disadvantage of person-centered is that sometimes those young people don't know how to express themselves. That's why they self-harm, because they're not good at talking. And they don't trust people either. So it can take a long time to build that trust and rapport, and for someone to open up to you. One of the things that can be useful here is an emotions chart, where you've got all the different emotions on a piece of A4 paper, and they can see those and they can think, oh yes, I feel like that and I feel like that, and they can tick them off. And you can actually get the ones with the emojis as well, how they're feeling today, and lots of other useful worksheets that allow them to express how they're feeling currently. And so that's helpful for people who are not good at expressing verbally. And obviously, psychodynamic therapy is going to be useful, because we know when we looked at the reasons why these severe self-defeating behaviours occur, is because somebody's had negative experiences in the past that's led them to feeling the way they do. And so looking at those things and making links between the past and the present can be really useful. However, it's also very difficult sometimes for people to look back at past traumatic experiences. And so, although it's useful to explore feelings and the past, it can also mean that self-harming becomes more severe at this time. The risk could go up because it's their coping mechanism. And CBT can be very useful for looking at a client's self-limiting beliefs and negative thinking and trying to change that. So let's recap on some of this. So we remember in a pluralistic approach that it's the client that keeps the client safe, not the therapist. There is ethical responsibility to report if a client is at risk of harm, and form a keep safe plan. We're responsible to the client, not for the client. And the therapist needs to be able to go there with the client and talk about difficult things. And that might be anxiety provoking for the therapist. So let's move on to discuss feeding and eating disorders. So these are closely related to self-harm, and many people can suffer from both. we need to remember that not all eating issues are disorders. So a disorder is a condition or issue that's been professionally diagnosed by a clinician. And if a person receives this diagnosis, then their issue is of a particular severity, frequency, and longevity to warrant diagnosis and treatment. But of course, we might get lots of clients that have got problems with food and eating. Lots of people eat their emotions, and people choose to eat more or not eat at all when they're feeling a certain way, when they're feeling anxious or lonely or sad. And sometimes when people do this, they can then feel bad about their behaviour, they feel guilty and ashamed, and it sets up a negative cycle. So we might get people that overeat, eat when they're stressed, or don't eat because they're stressed. So again, the first thing we need to do is assess the risk. So we need to bear in mind that self-harm may not be the original presenting issue. That may come out as a result of talking about anxiety or relationship issues. We need to bear in mind that other self-defeating behaviours may be present as well. And again, looking at their coping mechanism and trying to stop it immediately is not helpful. We can look at other coping mechanisms that can be useful, but we shouldn't expect people to change straight away. And we've got to remember that people want to be listened to and understood. So that's really important. And depression and low self-esteem are often present. So we need to remember that if somebody's depressed and really low, they're not always that motivated as well. And we mustn't try to fix the client. You know, that could be about therapist anxiety. So we need to assess the risk and work out whether there's just general poor habits of eating, occasional overeating, needing to lose a few pounds. That's probably something that you can deal with. Or is it a client that's experienced significant issues with emotional eating? And they're also experiencing anxiety and low mood and having difficulty controlling things. Or is it a client that meets the criteria for an actual diagnosis of a feeding and eating disorder? And with more severe cases, treatment can include hospitalisation due to the high risk. So obviously this will help us to assess whether it's something we can work with or not, and whether it needs referral on to other people. The categories of feeding and eating disorders listed in the Diagnostic Manual of Mental Health Disorders are anorexia, bulimia, binge eating disorder, pica, rumination disorder, avoidant or restrictive food intake disorder, other specified feeding and eating disorder, and muscle dysmorphia and orthorexia nervosa. Now, you may want to research a bit more about some of those, but for today we're focusing on anorexia nervosa, bulimia nervosa, and binge eating disorder. And there's a growing body of literature that is showing similarities between excess food consumption and addiction. And the reward mechanisms within the brain are implicated in certain binging behaviours. And they're similar to the mechanisms identified in substance and even process addictions. So many of the behavioural indications of problem eating behaviour, such as loss of control and the inability to cut down, are similar to those found in addictions. And some foods high in sugar and fat and certain processed foods also form a pattern of tolerance, withdrawal, binge and continued use despite the negative consequences. So very similar to addictions. And eating disorders are also associated with other mental health issues such as depression, borderline personality disorder and bipolar. And as we said with self-harm, the two are linked. So eating disorders and self-harm are linked. And these eating disorders often don't just originate from one cause. It's likely that several different elements or events have contributed to cause the first symptoms. And we know that the most common element around eating disorders is low self-esteem. And if we think back to how self-defeating behaviours are formed, there's negative experiences, usually in childhood, that leads to that low self-esteem, feelings of low self-worth, negative emotions. So let's look at the risk factors of somebody developing an eating disorder. So there's different risks. There's family risks, society pressures, and underlying characteristics. So having a family history of eating disorders, depression, or substance abuse can make it more likely. Being criticised for their eating habits, body shape, or weight. Being overly concerned with being slim, particularly if combined with pressures to be slim from society or for a job as well. And then certain underlying characteristics in a person, for example, having an obsessive personality, anxiety, low self-esteem, being a perfectionist, particular experiences the person has gone through, such as sexual abuse or emotional abuse or the death of a loved one. And difficult relationships, so society pressures as well. The difficult relationships, but stressful situations and problems at work or school or university, problems with other people and in the things we do in society can also be risk factors. So if somebody's got a lot of these different things, they're obviously going to be more at risk. And the Department of Health estimate that over 1.6 million people are directly affected by eating disorders. And reports estimate that 25% of people struggling with eating disorders may be male. And on average, the disorder starts between the ages of 16 and 18. So let's look at anorexia. So anorexia nervosa actually means loss of appetite for nervous reasons. And this condition is characterized by weight loss and excessive dieting. And it's most common amongst girls, but I do think that's changing. We're seeing more boys with the disorder. And the age that it starts to occur also seems to be going down. There's a younger age group now. So a person with anorexia can restrict the amount of calories they're taking into the point that they lose weight rapidly and become dangerously underweight. They won't see it like that. They'll usually have body dysmorphia and see themselves as bigger than they are. They'll consider themselves overweight no matter what they weigh. And they'll often exercise excessively as well. And sometimes they might take diuretics and other substances that can help them lose weight. They'll deny strong feelings of hunger, and they won't want treatment. And this is why sometimes they'll need to be hospitalised. It can lead to internal problems affecting the internal organs and so many things, and it makes it the most dangerous of all eating disorders. So people often need to be hospitalised and basically force fed until they put on a suitable amount of weight, and sometimes that's tube feeding. They will have an intense fear of gaining weight, and a denial of how dangerous their situation is. So here on the left of the screen, you can see the physical symptoms of anorexia, which are vast. You know, there can be extreme weight loss and lack of growth in children. They might be continually cold because they haven't got enough fat on their bodies. There can be muscle weakness because their muscles aren't strong enough. Poor blood circulation, loss of bone mass, which can lead to osteoporosis. They might have pale or dry or discoloured skin, and downy hair can grow on the body. They might have dizzy spells and feel faint because they're not taking in enough food. And their stomach can bloat, and they might have a puffy face and ankles. They may stop menstruation, and they will experience fatigue and headaches. And they might have all sorts of other illnesses as well because their immune system will be low. They might be dehydrated, lose their hair, have anemia. They could become infertile and can actually damage their kidneys, liver, and their heart. So clearly, it's a very difficult illness to deal with. And they may become withdrawn. They may have very rigid or obsessive behaviour around food. They might be restless. They might wear big baggy clothes to disguise. There'll be discomfort when they're faced with eating or food. And they might be frequently checking their weight, and they may have difficulty eating in public. And recovery, it's a bit like an alcoholic. They can recover, but they'll always have issues around food, and it can be a problem for the rest of their life. It's got the highest mortality rate of any psychiatric disorder. And the main reasons for death with anorexia are complications from starvation, abnormally low weight, and suicide. So it's a much higher risk than bulimia. And bulimia means the nervous hunger of an ox. And here in the middle of the screen, we can see the characteristics of bulimia: eating in a small period of time, a quantity of food that is larger than most people would eat. A sense that there's a lack of control over eating during an episode. And recurrent compensatory behaviours like self-induced vomiting, use of laxatives and diuretics, strict dieting and excessive exercise. And the binges and other behaviours occur at least on average twice a week for 3 months. And their self-evaluation is unduly influenced by their body shape and weight. And some of the symptoms associated with this is a chronically inflamed esophagus, and this is from the vomiting, and a sore throat and raspy voice. And your teeth wear out, decaying teeth, because of the acids in the stomach, and swollen salivary glands, and acid reflux disorders, gastrointestinal problems, and severe dehydration, electrolyte imbalance, and that can lead to a stroke or heart attack. And these people might base their worth on what they look like, but they'll still have this urge to eat excessive amounts of food. They'll be obsessed with it. And they might have mood swings and feelings of isolation or anxiety or depression. And signs you might notice is not as clear as with anorexia, but it's usually noticed when people constantly visit the toilet after eating, and they will be purging. You may notice over-exercising or the use of laxatives or diuretics, avoidance of social occasions, or excessive spending on food or hoarding of food. So people with bulimia are more difficult to spot than anorexics. And they might not tend to lose loads of weight. Their weight might fluctuate, but you might not notice it that much. And in some cases, the condition can go on for many years without being detected. And so, as with all these other self-defeating behaviours, the binging might start because of an anxiety-provoking or stressful event. And the binging gives a feeling of comfort. But of course, afterwards, there's feelings of guilt and shame and often panic. And then they need to rid the body of that excess food. And so will induce vomiting and sometimes use laxatives. And sometimes then also exercise. So that's anorexia and bulimia. And the other one we're going to look at on the right of your screen is binge eating disorder. And this is really when they have periods of compulsive overeating, but they don't purge. So they're typically overweight or obese, but not always. So some of the symptoms of binge eating are eating large amounts of food in a specific period of time, continuing to eat even when full or not hungry, eating rapidly during periods of binging, eating until they feel uncomfortably full, eating alone or in secret, frequent dieting, but often not getting the weight loss because they're just yo-yoing, feeling distressed, guilty or ashamed of eating, and they may have high cholesterol or high blood pressure or osteoarthritis. There could be a decrease in their mobility, they could develop shortness of breath, and all the other issues associated with obesity can be present as well. So they could develop chronic health problems such as diabetes or cardiovascular damage and gastrointestinal problems. So with these eating disorders, you know, there is a high risk, more in some than in others, but we need to take all these eating issues seriously. And we need to remember that counselling and psychotherapy work as adjunctive treatments to medical intervention, not instead of. So we always need to be thinking about the levels of risk, not just at the start of therapy, but throughout the therapy process, because as we've seen, maybe you're talking about the past and traumatic events are being re-experienced, which may make it more difficult for a person, and therefore their eating disorder gets worse at that point. So the risks go up. So we need to bear that in mind. And we need to think about whether we can actually deal with this, whether we need to refer to a GP. If somebody's got physical symptoms, they should always be referred to their GP to get checked out. And do we need to refer to specialist services? If a person with anorexia wanted to see you as a private therapist instead of a hospital, you really need to think about why. Because individuals with eating disorders, especially anorexia, are often careful to avoid diagnosis and often refuse or don't engage with treatment. You know, so why do they want to see you? Are they trying that instead of going to a GP? Do they think that's an easier route? Are they taking it seriously? You know, you need to think about these things. And we have a duty of care. So if a person's life is at risk, we need to refer on and get help from medical professionals. And as I said earlier, in some cases, hospitalisation is the necessary course of action. If a client has had specialist care, so if somebody's been hospitalised and they've got to a suitable weight and they're a bit more stable, then counselling and psychotherapy can help then. And our pluralistic approach helps us to recognise that eating issues are biopsychosocial. And so there's no single cause and can be born from a combination of personal, social, cultural, biological and genetic factors unique to that person. And some clients have eating disorders even without receiving a diagnosis and can feel out of control with maybe compulsive overeating or rigidly controlled eating, and so they can arrive for therapy trying to control those behaviours, but still find it really, really difficult and powerless to change. And you know, we can really try and help them with that. But again, you're looking at your own competency levels. And we need to remember that depression, anxiety, OCD type behaviours and self-harm are all associated with eating issues. And so we might not be just dealing with one self-defeating behaviour, but many. And are we equipped to deal with that? So let's look at our pluralistic approach and how it could help. So the main key to success is the building of the rapport between the client and the therapist. That relationship, our own reliability, constancy, flexibility of technique, and our stability and an open and honest relationship with that with that client is what is going to be the most successful for them. We know that the relationship is of vital importance. And so when we're using this pluralistic approach with eating disorders, addictions, and self-harm, we're sort of going through this process. We're making sense of the problem and its development. So as part of the initial assessment and case conceptualisation, clients can be assisted to understand their behaviour as meaningful in some way, to try and raise their compassion to their self and reduce the shame that they feel. And we need to explore limiting beliefs and attitudes. You know, this has all come from their inner dialogues, which are self-critical. And obviously one of the things we can use here is CBT, but also TA, looking at the way that they communicate and what their self-talk is like. And they clearly need to learn new skills. And it's looking at what they feel is normal and helping them to choose and implement more positive behavioural changes and replace old habits. And we looked at motivational interviewing when we were talking about addictions, and this is also useful here, motivational interviewing approaches, looking at discrepancies between what they want and what they're actually doing to themselves. And self-care and learning to tolerate stress. So often these clients are poor at attending to their own needs and may need to learn self-soothing techniques, but also learning to tolerate their painful feelings, learning that their feelings will change. Emotions are energy in motion, so they will change if we can sit with them for a while. And clients becoming more in tune with their feelings, and looking more at focusing on their inner resources. And of course, we need to heal old wounds. So we know that these coping mechanisms started because of loss, abuse, trauma, negative experiences. So assisting them to tell their story in a supportive and listening and understanding environment is really useful. And clients can find that cathartic. But we need to remember that timing is crucial there. We mustn't do that too soon. The client needs to be ready for it. And also things like writing, art, sharing photos, and using Gestalt empty chair work and other Gestalt self-awareness work can be really useful here. And we need to help them find alternative behaviours. And this will be sometime on in the therapy, not at the beginning. And so we're trying to assist them to find alternative resources. And that can be creative means or sports, other social support, whatever is suitable for that client. And we're doing that equally with them. What do they think would help them? What could they try? And we're trying to improve interpersonal relationships. So making use of that social support can be difficult for some clients, and the therapeutic relationship can model what a good relationship looks like. And that can help the client find the benefit in sharing feelings with others and their experiences, and to reach out to others. So the relationship with us and our client is so important, and they can learn from that model of a relationship. And at this time in your training, it wouldn't be appropriate for you to work privately with clients who had severe addictions, self-harming behaviours or eating disorders. You're going to be working, if you're working in private practice, you're working alone, and although you have supervision, it would still be a very, very challenging, difficult area. If you're working, if you want to try this sort of work, if you want to work in this field, then it's best if you're working as part of a team. And so working in a placement with specialist training and specialist support and supervision, where the procedures and policies and ethics and boundaries are really clear, is the best option for you. So that's what Chrysalis would recommend if you want to go into this field of work. So that's it on self-harming behaviours and eating disorders. There's a lot more in the module notes that we haven't gone into today. But for now, we need to move on to looking at supervision and contracting in supervision. So if you're working on a placement or you're employed by an organisation, they is probably going to have on-site supervision, which will be mandatory for you to attend. And they can ensure that your work is being overseen by someone who's more qualified and more experienced than yourself, hopefully. But if you need to source a supervisor privately, whether you want that for individual or group supervision, then you need to negotiate and clarify the relationship so that it works harmoniously for you and for your supervisor and is beneficial for your clients. So if you remember the seven-eyed supervisor, we've got different ways of working in supervision, and we need to think about all those things when we're looking for the right supervisor and forming a contract with a supervisor. So let's look at some of the things we might consider here. So when we're looking for a supervisor, we might think about particular characteristics. You know, what do I want, a male or female supervisor? Would it make any difference? Would it be good for me to actually work with a man if I'm not quite as comfortable with men for whatever reason? What age? Would age make a difference to me? Do I want someone, you know, around the same age? Is a younger person, am I going to feel that they know enough if they're younger? What about their sexuality? Does that matter to me? And their culture? So those things are worth thinking about. And then the theoretical orientation. So really, if you're working in a pluralistic way, you want a supervisor that also works that way. If they're just person-centred, or if they're just CBT, are they going to be able to help you, give you what you need? And also, have they got experience in a particular setting or context? So, for example, if you're working in a school, have they worked with young people? Do they know what it's like working in a school? Their qualification and experience is obviously important as well. How long have they been doing this? And their working style. You need to just be able to gel with that person. They need a working style that suits you. And what days and times are they available? Are you going to be able to fit in with them? And of course, the location. How far are you willing to travel? And their venue. Is their venue comfortable for you? You know, you need to be somewhere where you feel at ease. And the frequency, can they offer you the frequency and the amount of time you need? And what's the cost? Because that's important too. And obviously, is it individual, group, etc. So there's some of the things that you need to think about when you're looking for a supervisor. So even if you're working with a placement at the moment and you intend working with an organisation, at some point you might be working for yourself from home. And it's always advisable in supervision to have a formal contract in place. And this allows both of you to consider the relationship and your mutual expectations of it. And so your contract with your supervisor will usually be put together by her for you to consider. But that can obviously be discussed and negotiated. And it can be written or it can be verbal. But some of the things it should cover is obviously the practicalities. So what time is it going to be? Where's it going to be held? How often? How long are the sessions going to be? The payment and payment terms. And what to do in an emergency situation. Can she be contacted if you see a client and they're suicidal? Can you contact your supervisor or not? What are her boundaries around that? And accountability, so responsibility for client work, monitoring and feedback for employers and professional registers, professional accountability, professional memberships, insurance, codes of ethics, duty of care, management of critical incidents or complaints, and the number of clients on which you can be supervised. So all those things are important, and sometimes we don't think about these. It's clear that you can't talk about every client at every supervision appointment. There's not enough time to do that. So how are you going to work out what you want to take to supervision on a particular day? It's what is the priority at the moment? Are there any high-risk clients? Are you struggling with your feelings about a certain client? Is a client triggered you? So these are all things to think about. And you need to talk about confidentiality, the limits with respect to clients, boundaries, your contract between you and your clients, the status of your client notes, supervisor and supervisee notes. You need to think about if you're carrying notes around to your supervisor's appointment, have they got any personal details of your clients on them? Because then you shouldn't be carrying them around. And presentation in supervision, the use of notes or transcripts or recordings, thinking about that and how feedback is given. And professional development, how supervision sits alongside or supports your continuing professional development. Supervision, as we've discussed, is a big part of your professional development. You learn an awful lot from good supervision. And writing of reports or providing references. How does your supervisor feel about doing that for you? Is there any charge for writing references or reports? These are all things that we need to find out. We don't know if we don't discuss them. And also review and assessment. So how frequently are you going to review the relationship and evaluate whether it's working for both of you and what you're learning from it? So there's actually quite a lot here, isn't there? A lot to think about in supervision. And this contract is important to make sure you both know exactly where you stand. Who is going to take responsibility? If you have a client you feel is a real high risk and you don't really know how to deal with it, is your supervisor going to be available to talk about that? Are they going to advise you about that and you deal with it? Or is your supervisor going to deal with it for you? You know, these are all things that you need to discuss. So lots to think about today. It's quite a heavy subject. And as I say, there's a lot more. I'm going to stop sharing. There's a lot more in your module notes. And obviously you can clarify a lot more of this when you have your session with your tutor and ask a lot more questions. But I hope that's given you a good insight into self-harm and eating disorders, and also more about supervision and the importance of finding the right supervisor and setting a contract. So that's it for me from now, and I will see you again at module 9. Okay, thank you for listening. Hope you enjoyed it. Bye.